I'd like to introduce our first speaker, Dr. Don S. Dizon, is a professor of medicine and surgery at Brown University and serves as the director of pelvic malignancies at the Brown University Health Cancer Institute. He also holds the role of associate director for community outreach and engagement at the Legoretta Cancer Center, where he is dedicated to bringing compassionate care to communities in need. He is also the founder of the Oncology Sexual Health First Responders Clinic at Brown University Health, a groundbreaking initiative that addresses the often overlooked aspects of cancer care. In our first session, he will talk about how a breast cancer survivor often finds herself or himself at a crossroads, needing a roadmap after a cancer diagnosis. Diba, for most of us, after receiving the diagnosis, I know for most of us, yung tuliru ka eh. Diba, you don't know, sometimes you don't know which is what, and then kung may nagsasalita, pasok dito, labas dyan. In fact, ako after my cancer, 3 years after my eldest sister got it, tapos I had to go to the States to help mentor her through the journey. Tapos pinuntahan namin yung doctor niya. So ang sabi ng doctor, he described to her the results of the biopsy, that she had cancer, blah, blah, blah. When we got home, sabi ng kapatid ko, buti na lang wala akong cancer, no? And then I said, what? And buti na lang wala akong cancer. Sabi ko, but you have cancer. That's what the doctor said. No, he said I didn't. So it's like you hear what you want to hear. So we called up the doctor, and sure enough, it was cancer. In any case, that's just a case in point. In his talk, Dr. Don Dizon will discuss the initiative of the survivorship journey. He tackles the fundamental questions. What is survivorship? When does it begin? And what are the essential components of care? What is one's unique survivorship goal? And who is the crucial player or players in one's care? Dr. Dizon provides insight into a survivor's ever-evolving new normal to stay physically, psychologically, sexually, and financially healthy. Please join me in welcoming Dr. Don Dizon.
I am very happy to be able to do this presentation. My name is Don Dizon. I'm here in Providence, Rhode Island, where I'm a professor of medicine and surgery at Brown University. And I also direct a sexual health clinic for cancer survivors. Just to begin the context of this conversation, it's important to know that the definition that is most relevant for people who have been diagnosed with cancer begins survivorship at the point of the initial diagnosis. That is where I consider the journey with cancer to start. And even though you are treated for cure, and hence most people think survivorship starts when that curative treatment ends, the incorporation of survivorship from diagnosis then can last beyond and include people who continue on medical therapy in an extended adjuvant context, but also includes people who have had metastatic disease come or have recurred, or who continue on lifelong therapy. There may be periods where people on those treatments are cancer-free, but that also includes this dynamic state of survivorship. So the inclusion of people within the survivorship realm who have just been diagnosed, who have just received curative treatment, who have relapsed, who have continued on treatment for metastatic disease, all of that is really important because the needs persist and are not limited to solely those who have been, quote, cured of their cancers. And I'm going to explain that further. These are the four components of what we think of when we think survivorship care. So it's detection and surveillance, not only of a recurrence or a metastatic disease, but it's detection of a new primary cancer, because we understand people who have been diagnosed with cancer once are at risk of having a second cancer diagnosed. It is also about the detection and the treatment of late and long-term effects of cancer and its therapy, whether that be accelerated bone loss or osteoporosis, whether that be cancer-related fatigue that is unrelenting, whether that's brain fog that prevents someone from returning to their job. There are these late effects that people will need help with far beyond that cancer diagnosis. It is about prevention. It's about wellness. What can we do to keep people healthy so that they not only survive this cancer, but also survive preventable illnesses like heart disease? And then it's care coordination. And this is critical because we know in the past, people who have been diagnosed with cancers tended to fall in the cracks. They were not getting, for example, screening for secondary cancers. If you had breast cancer, it was very unlikely you were going to be referred for a colonoscopy to prevent colon cancer. You were also less likely to get the flu shot, for example, because no one took ownership of that care. This tenet indicates that your oncologist, while important in your care, needs to talk to a primary care doctor to ensure that services are delivered to people even after they've been diagnosed with cancer. And ultimately, the survivorship term embraces what's called a new normal, that life after a cancer diagnosis, it is forever change. It doesn't mean it's worse, but it is different. That process does not happen overnight. It actually takes time. The new normal is something that reveals itself to you over time. And I don't think we prepare people enough for that, especially if one has a relapse or develops metastatic disease. The normal is evolutionary. It is not static. And we also have to understand that within this new normal, there is this sense of psychological trauma, which is oftentimes most pronounced for people who are receiving curative treatment, because when that treatment ends, it's oftentimes when we are able to process what just happened. And it is not uncommon that people will complete first-line therapy with curative intent and not understand what just happened, not understand their diagnosis, not understand the stage of their cancer diagnosis, not even be able to name the regimen that they were just treated with, and not understanding what the future will hold for them. Indeed, it can be so traumatic that up to 60% of people with cancer have a post-traumatic stress disorder, which in some people can be quite disabling. So what does this new normal sort of consist of? And there's multiple aspects, and I'm going to cover some of them here. But fatigue is very common, and it does not end when the treatment ends. For a lot of people, there is also a fear of what the future holds. Will you sustain a recurrence? And if you do, will you have progression? And these, again, can be part of that PTSD. There are changes to intimacy and sexuality. There is the curiosity and the ambition to have a healthier lifestyle, which is relevant even for people who have developed metastatic disease. And then there's the search of opportunities and financial stability when indeed cancer closes a lot of those opportunities. So in terms of cancer-related fatigue, it is actually one of the things that is most problematic for people who have had cancer, and even after they are no longer under treatment. It can manifest as this exhaustion, but it is not necessarily physical. It can be emotional, and it also can be this cognitive exhaustion, this sense that I just can't think anymore. It is present in almost everyone, and in 50% of those, it's present when treatment completes. It seems to be worse among people who receive chemotherapy, but also those who experience menopause, even accelerated menopause. It is more prevalent in people who've had psychiatric diseases, and it is tied to sleep disorders. There are things that we can do to help evaluate fatigue and not just accept it as a known complication. There can be things that can make it worse. Anemia, for example, the onset of thyroid disease, which is quite common, especially for people on immune checkpoint inhibitors. Things that people can do, though, to prevent or mitigate fatigue is to increase or maintain physical activity, which can be quite difficult if someone is exhausted. There's also psychological support that can be used to help with it. And at its worst, we can provide psychostimulants like methylphenidate. It is also important to note that steroids can sometimes help acutely, but it is not a long-term solution. Fear of recurrence is the sense of not knowing, again, what's going to happen. It's the sense of waiting for the other shoe to drop, and worrying that symptoms that you might have reflect a recurrence. The risk factors are known. It happens in younger people with cancer, those who have kids, but also those with more social isolation, and then a more advanced stage. But also important, it's not just the person diagnosed with cancer that has this. It is actually their spouses, their loved ones, their children, their parents, caregivers have the same fear that their loved one will recur. And sometimes it can be more devastating for them than for the survivor. There was actually this study that was done years ago now called Conquer Fear. And what they were able to show is that psychological support, counseling, is effective in helping to address fear of recurrence, and it can lead to a long-lasting change within that fear of recurrence. The thing that's important as well is that fear of recurrence seems to be worse in the first 6 to 12 months after treatment ends. And then I think the tincture of time does help. But people should not have to suffer for that first year. And we now know that counseling can be effective. Sexual health is another aspect because chemotherapy, radiation, surgery, all can change body image, all can change intimacy, and all can change the milieu of what used to be one's normal sexual activity. Importantly, sexual health does not imply sexual activity. There are these multiple, what I term domains of sexuality, and all of these can be challenged after someone is diagnosed with cancer, from intimacy and the experience of sensuality, changes of body image, changes in arousal thresholds, or areas of the body that used to bring about arousal, desire, climax, and even satisfaction. And these are relevant both in men as well as in women. This is a model that explains sexual health in women specifically, and I use it because it doesn't rely on the physical manifestations of sexual activity. This model proposes that women become sexual because of a want of intimacy in their lives, which helps wake up their body so that when certain areas are touched or stimulated, they experience arousal. Arousal feeds desire. When desire is satisfied, intimacy is propagated and the circle prolongs. Cancer can break each of these arrows, and unfortunately, it can be very confusing when that happens. But as important, you'll notice in the figure, physical activity is not something that is inherently important in women's sexual health. Indeed, this link between desire and satisfaction can happen with non-sexual activities, such as when your partner makes a nice dinner for you, when they do the laundry without being asked, when they bring you flowers. There is a sense of intimacy and satisfaction that comes with non-sexual activities. And the importance here is that women experience intimacy and sexual activity as completely separate domains. All right. So most of the time, it's really important to identify what women are looking for, what have they lost, because often, even though they say they lack desire or they have no sense of libido, what they're actually looking for might be enhancing intimacy. There are approaches to treatment which makes it important for your doctors to ask the questions. And the way that I would bring this up is to think about vaginal health separate from sexual health. Vaginal health is where we address the genitourinary symptoms of menopause. It's where I talk about the use of a moisturizer, not only within the vagina, but in the vulva 5 times a week. So frequent use of a moisturizer as you would take care of the skin or your face. We can also talk about hormonal therapies as a way to improve vaginal health. And we're not limiting ourselves to just estrogen. Here in the United States, there's a drug called progesterone, which is a DHEA agent. It's a dihydroepiandrosterone, which can improve sexual function, improve vaginal health, but not raise estrogen levels beyond the upper limits of normal of the assay. For sexual health, this is the things that we can do to help improve pleasure. This is where we talk about lubricants or dilators, and it's where a pelvic exam becomes important, especially if someone is experiencing pain with any type of penetrative activity, because there can be a simple solution, especially if that pain is occurring in the entry of the vagina and not in the vault itself. And for women who have pain that's limited to the entryway, 4% water-based lidocaine can be very effective. Healthy lifestyles is something that is important, not only to people who have been cured from cancer, but even for people who are living with cancer as a more chronic illness. They too still want to be healthy. And we can think of it as a balance between the intake and the energy expenditure. And the goal here is to maintain weight. So not to lose excessive amounts, but also to prevent weight gain. And what's important here is that although we're talking cancer, we need to understand that heart disease is the #1 killer in women, and that we can impact overall health, overall outcomes with walking at least 9 hours a week. So this is something that is within people's control, no matter where they are in their cancer experience, whether they're cured, whether they're on treatment, whether they're metastatic. These are the recommendations from the American Cancer Societies to maintain a healthy weight, not to lose excessive amounts, maintain activity, eat healthy with a balanced diet of fruits and vegetables, limiting the intake of processed foods, and limiting alcohol intake. The other issue here is about financial health, and sometimes it's called financial toxicity, or other term would be financial hardships. And financial hardships is important because it incorporates what a family is going through after a cancer. And we do know here, even in the United States, that there is an expectation of significant out-of-pocket expenses, even among people with insurance, private insurance. But what's important about this is that running into issues with financial needs at diagnosis may impact quality of life. But if it happens due and during treatment, there is a higher risk of dying of cancer. And it might be because we are asking our patients to make very hard choices between food or chemotherapy. But it is also this sense of maybe hopelessness that the life after cancer is one of financial ruin, and people may be withdrawing from therapy because of it. It's important to understand survivorship in itself is a form of supportive therapy, and that the goals of survivorship will change and evolve as someone, or I should say, depending on where someone is in their cancer experience. If the goal is cure, then we will want to address healthy lifestyles, but also prevent symptoms. Those are still the same goals within people who have a recurrence or experience metastatic disease, although the treatment goal might shift from cure to control. We still need to address symptoms, and they may still have questions of healthy lifestyles. But as someone becomes advanced, or someone that lives with more advanced disease or becomes more symptomatic of their cancer, the goals might switch away from that into more palliative care and symptom management. And then for people with end-stage disease, we want to ensure that every day that they live under their own terms, as comfortable as they want and can be. So this is where hospice can kick in. At Brown, we've started something called the OWLS Clinic, and this was intentional. It's an oncology, wellness, lifestyle, and survivorship program. It is open to people diagnosed with cancer, and it is open to them throughout their treatment journey, recovery, recurrence, or living with metastatic disease. And in fact, about 20% of the people seen in OWLS are living with advanced or metastatic disease. We have an intake service. It is run by my colleague, Christine Duffy, who's an internal medicine doctor, and she has assembled this multidisciplinary team of experts outside of oncology who she reports patients seen within our group, and collectively, we can create a plan and get people into referral streams in a more streamlined way. Again, the lead here is Christine Duffy. She's an internist. As of 2 years ago, they'd seen 90 patients. Since then, we've opened this up to people being treated for hematologic cancers and who have undergone a bone marrow transplant. I think what I want to leave you with, and we can have a robust conversation about what survivorship care means in the Philippines, is that survivorship care is the manifestation of hope. Hope for a better life after cancer, hope for a healthier life after cancer. No matter if you were cured or if you're living with metastatic disease, there is always going to be room for hope. And with that, I'll close, and I'm happy to take any questions, but thank you so much for having me.
Maybe I can throw the first question, Doc. I've been diagnosed, I was diagnosed 19 years ago, and I just like to know what kind of lab tests are still necessary, or imaging tests, if at all, because there are different strokes for different folks, I think, here. Yeah. Some breast cancer survivors have PT scans every 6 months, some have every year. I only get a mammography, but what would be the ideal?
Yeah, so that's a question that I still get here in the United States. And I think there's some widely held beliefs that people who have been diagnosed with cancer have. They really want to know that they're okay, especially after the treatment has ended, because there's a fear of recurrence or a fear of progression that's very, very real. And I think it makes sense. If I get scanned, the chances are, if I have something, you're going to find it quicker. And if they find it quicker, we can treat it quicker. And my chances will be better and I'll live longer. That's actually been tested, that theory, by subjecting people to a very aggressive screening program where they got blood work every 6 months, imaging every 3 to 6 months, in addition to mammograms, versus something more conservative, which is what you're describing. Mammography every year, with or without an ultrasound, maybe without an MRI of the breast if you are at risk of a breast cancer. um, examination, history taking, and seeing your doctor regularly. So aggressive follow-up versus not aggressive follow-up. And when we see the results, they are not different. So an aggressive schedule of follow-up testing in the absence of symptoms doesn't help you live longer. Okay. So that's a very difficult thing that I do take time to explain as to why the practice in the United States is not to do imaging beyond breast mammography if someone feels well, not to do blood work just to make sure is not something that we suggest people do. I have young women who are diagnosed with aggressive cancers, got chemotherapy, who are not willing not to do anything. And that's where the conversation comes in. And it's a discussion that I make with every single woman or man that I treat about what they are willing to do to feel comfortable versus what the evidence dictates. Most people are accept doing exams and follow very closely, doing imaging and testing when indicated. Some want to do the PET scan once a year, want to do a CAT scan at least every 6 months. And if things are good at 3 years, then they go down because it's a very life-changing circumstance to be told you have cancer. And the last thing someone needs to do is give you the false reassurance that everything's going to be okay when no one can convince you that it's going to be okay. So I guess the evidence-based answer is that you do not need to do testing if you feel okay after a cancer diagnosis. That needs to be balanced by what will help you get through this illness in the short term and then as time passes on.
Okay. Thank you very much, Doc. We have a question from the audience, ma'am.
Yeah, good evening, Doc. Veronica from Hearts of Hope Society Cancer Support Group. I'm just curious because, of course, if the patients are already survivors, of course, we don't want the cancer to recur. So maybe you can just enlighten us the risk factors in cancer recurrence, so somehow the survivors can avoid those risk factors. Thank you.
Yeah, so when we talk about risk factors, we talk about things that we can modify, right? Things that are within our circumstances to change, and then there are things that we really cannot change. So the things that you can do to reduce your risk of having the cancer return are things like a healthy lifestyle, getting some exercise in, like we talked about, and eating a more balanced, heart-healthy diet, okay? Avoiding alcohol or limiting your alcohol intake, because all of those things as factors are associated with increasing risks of relapse, okay? Then there are things that we cannot really change. We can't change the stage of diagnosis. If it was in your lymph nodes, we can't change the risk that the lymph nodes were positive, because then that risk of having disease or single cells that are circulating in your blood, that is going to be higher if it was in your lymph nodes versus if it was not in your lymph nodes. We can't change tumor size, but that's the reason you got treatment. So taking the hormone blocking treatments is important for people with hormone positive disease. We can reduce your risk by 50%, but it requires that people are able to take the pills. So I think that's one of the things that I would suggest we think about. The other thing about that is detection. And I understand very clearly now, after over 20 years in practice, that the way someone looks and feels in their skin, the symptoms that they experience, tell them something. And they tell them something when it's something to worry about. So trusting what your body tells you is also very important. So bone pain that wakes you up at night is something to bring to your doctor. Bone pain that you get when you're done walking around and goes away with rest and goes away with sleep, that's not something necessarily to worry about. That should be arthritis. But bone pain from cancer actually wakes you up at night. So rest actually aggravates it. Something to look for. Increasing fatigue or tiredness, like we talked about, that comes on suddenly and doesn't go away, is something to talk to your doctor about. And when you talk to your doctor because you're afraid of a recurrence, and this is what I do in terms of ordering tests. Someone might come into my office and say, I just don't feel right. Something's wrong and I don't know what it is. That is a flag to me to image. Even though they can't say it's, I'm having trouble breathing, or my abdomen is very disturbed, or I'm fatigued all of a sudden. Even if they just say something feels wrong to me, I will image. But if your doctor isn't answering the questions that are worrying you, do not be afraid to say, I think I might be recurring. I want to check to make sure I don't have a recurrence. Saying those words will prompt more direct imaging and conversations. And sometimes we as doctors just need to hear what's on your mind.
Okay, I think we got that. Do you have time for 2 more questions, Doctor?
Yes, yes.
Okay. Ma'am?
Good evening, Doctor. I'm Charity. I'm a
Hi.
stage 4 cancer survivor.
Great.
8 years. First of all, I want to second what our host said. You have really nice glasses. But my question, and the other thing is, you have really very intuitive answers and points that probably some of us have heard for the first time. Like, it's important how you feel, your overall well-being, as opposed to getting checked every now and then, right? I guess my question is this: as we come together to think of a survivorship program, as a cancer coach, the most often statement I would hear from people who have had recurrence would be, I did everything. I checked all the boxes. I ate well, I slept early, I exercise, I stay away from alcohol, I don't eat processed food. Why the recurrence? And this is why I also love the term that you use. You hardly use prevention, you use the word risk reduction.
Right.
So for us who are coming together to put programs for survivorship, what would be your input on that?
Yeah, that is a very common thing. Even when someone is first diagnosed, because cancer oftentimes will happen when you're your most healthy. And after you're treated for cancer, you try to do everything correct and really follow, even take the pills that are causing you to go into menopause and ruining your life. You take those pills every day, and yet the cancer still comes back. There is no good answer to the why, but I think the more important message I try to tell the people I treat is that it is not your fault, that you didn't deserve the cancer, that you're not to blame for the cancer, and that you are not to blame for the recurrence. Everybody has a risk that it might come back, and some people it does, and I can't tell you why. And the same people with the same tumor characteristics, the same tumor stage, it doesn't come back. And no one can say why that happened to you. So all I can say is with 100% certainty that you did not do anything to let that happen.
I think your answer is very grounding, especially for our upcoming workshops. Thank you, Dr.
Yeah.
Lisa.
Okay, we have another question from the audience.
Hi, Dr. Dawn. The question that I wanted to ask is something that I know most of the women here would love to ask but are hesitating to ask, and it's about sexual health. This is an issue that is most important to discuss especially not only among breast cancer survivors, but also among women who are in this stage, especially when they are in their perimenopausal stage and are having to adjust to the diagnosis. So my question is, when do we start discussing sexual health when a woman is diagnosed with breast cancer, and what are the ways that they can address the issues that you brought up, and in the context of our culture where sexual health is only discussed when we are only talking about the disease, rather than discussing this in the context of maintaining health. So how do we bring this up to our doctor who's supposed to be talking about our disease, our diagnosis, and the treatment process? And then in a context such as ours, how can we as a support group talk about this, to include this in the complete care package that we want to bring to our the women that we are serving?
Yeah, I think those are great questions. And first of all, it's a really unfortunate message that I don't want to leave you with, that you have to be the ones to bring it up to your doctors, because there's still that power dynamic, and you don't want to embarrass your doctors, and you don't want to be embarrassed by how your doctor responds. You're a surgeon here in Providence, Rhode Island, every time, and as a woman, every time her patients say, you know, my vagina is dry, she shuts them down. She doesn't want to talk about it. She doesn't want to go there. She doesn't want to hear it. And she told me this, I just thought how terrible it is for your patients. So the one thing I would say is, in the papers you give to the doctors, if you just encourage them to mention sexual health as a side effect, women will remember, women and men will remember they said it. Yeah. And when they're ready to talk about it, they will remember which doctor opened that door. And I think what you're asking is, how do we get that door open so we know it's something that we can talk about? Right. In the absence of that, find out who the advocate is in the treatment center. For women with metastatic disease, their doctors never refer them to me. They hear about my service through their infusion nurse or their social worker, or they find me online and they make appointments themselves. I've had a colleague ask me, who can see my patient with brain metastases for sexual health issues? And when I said, you know, I have the clinic, I actually see these patients, he was surprised, because he only thought I saw people who are cured. Okay. So what you can do to advocate as part of this group is be the ones to say sexual health, sexual relationships suffer after cancer. Make sure you know this going into this. And if it's happening to you, don't be afraid to reach out. And then there are certain things that you can offer women, because it's so common. Vaginal dryness, you can be the ones in your pamphlets to say, use a vaginal moisturizer 5 times a week, internally and externally, and make sure they understand a moisturizer is not a lubricant. And that a moisturizer, like coconut oil, probably not a good idea to use it inside the vagina. But just giving that advice of, use a moisturizer like you take care of your face, like you take care of your hair, 5 times a week. That is very good advice that can help a lot of people, so that they have it and they don't necessarily need to ask about it.
Those are really good points.
Thank you very much, Doctor. We'll take 2 last questions from the floor. Ma'am?
Yeah.
I wanted to ask what hormone replacement you mentioned, because I have always thought that if you're taking a hormone blocker, then obviously you can't take a hormone replacement.
Yeah. So that's a very big area of controversy here in the United States. The short answer is oral pill hormone therapy is contraindicated in hormone-positive breast cancer. Where I have prescribed estrogen is in someone who had a hysterectomy for some other reason in the past, got triple negative breast cancer, and had really horrible hot flashes. I have prescribed hormone therapy for her because the data from our randomized trials, which are not good, showed that people with triple negative breast cancer don't have a high risk of recurrence if they give them estrogen. Okay. But for hormone positive breast cancer, if you're taking an aromatase inhibitor or a tamoxifen, you can take vaginal estrogen preparations. Like there's a tablet, 10 micrograms is what's available here in the United States. That is a very, very, very low dose. It doesn't go into the bloodstream, and the effect is local. And you can use it once a day for a month, and then go to 2 times a week, and have sustained improvement in dryness, in discomfort, and it can also have improvements in sex. So vaginal preparations are the ones that we would suggest for hormone positive breast cancer. And then there's another type of hormone called DHEA. In the market here, it's progesterone. It's dehydroepiandrosterone. That too can help with sexual side effects, and it does not increase estrogen levels. So that's DHEA.
If someone's had a double mastectomy, and so you don't do mammograms, would you then recommend ultrasounds once a year or MRIs? I'm BRCA1 positive.
Yeah, so if you had the double mastectomy and they removed all the breast tissue, so that's really from your surgeon, you can ask him that. Then you don't need any imaging. Really important to have the chest wall examined. Yeah. Because if you're going to have recurrences after double mastectomy, it'll be on the skin, which can present as a pimple, or it can be with a mass at the musculoskeletal in the muscle, so you can feel that. So very important, no imaging, but physical exam becomes crucial.
Okay. Thank you very much, ma'am. For our last question for today.
Okay, good morning, Dr. Dizon. So I'm Ron from ICANSERVE Foundation, Cebu. So I would like to ask this question because I think a lot of women are guilty about this. So because of our paranoia to have recurrence, we tend to overdo it or overload with supplements or vitamins. Like me, there was a time that I used to take 10 or 12 vitamins or supplements. So I would just like to ask, can you give us, I know it's bad for the liver, can you give us a list of vitamins that would really work for us so we could take out those that would not benefit us as much?
So there's a nice website you can look at. It's from Memorial Sloan Kettering. It's the mskcc.org. They have a very big list of vitamins and also herbs. And they go into the scientific details and the evidence behind them. The problem with answering a question like yours, because I'm going to conclude with, I don't know if I can, is these are not like medicines. So the variability in who's producing it, whether it's available as a powder versus a capsule versus a tablet, is very variable, including not even where it was produced, what country. Was it in the Philippines? Is it Chinese made, Japan, America? So if I told you, vitamin D, very good. You should, calcium and vitamin D, those are both very good for you, right? I couldn't tell you which pills to take, but I can tell you vitamin D and calcium is very good. My take on all of this is that I have 2 rules by this. One, does it make sense to you? And does it sound like it could help? And number 2, will it, make sure it's not too expensive? Okay, so none of this should put you in the poor if you're going to be, if you're going to take these vitamins. My mom, and Kara has met my mom. You might have met my mom when I was in the Philippines. She takes a ton of vitamins. because it helps her feel in control. And I think that's okay. I think it's okay. But you said one thing about affecting your liver. Make sure you tell your doctor the vitamins you are taking, so that at least you can get some monitoring to make sure they're not hurting you.
Thank you very much, Dr. Dizon. Again, he's online from Providence, Rhode Island, where it's almost midnight, 12 hours in difference. So we'd like to send you off to sleep, and sweet dreams, dream about us.
Thank you. Have fun.